Ladies and gentlemen, I all wish you a warm welcome on the European Public Health Conference 2013 here in Brussels. Dear European Commissioner, dear colleagues, ladies and gentlemen, it's my great pleasure and honor to moderate this opening session. Also on behalf of the Belgian Association of Public Health, partner of this conference, I am delighted to receive you here in Brussels at the beautiful Conference Center Square. I am sorry that we could not arrange for the sunny weather of Malta last year, but on the other hand, I am convinced that you will also attend an interesting and pleasant meeting. In the first place, of course, scientifically. But since the rigorous and high-quality system of selecting abstracts for this conference is beyond any dispute, I can, without fear, focus on some other aspects that also contribute in making a meeting like this, one with a lot of variety and surprises. For instance, our charity event. We decided to continue this idea, also organized in Malta, but we adapted it to the local weather conditions. Instead of swimming outside, everyone is now kindly invited to jump on one of the home trainers which are available at the exhibition stands. You find more information about the charity event in your conference bag, but I would like already to ask you all to stick the blue, red or green label on your badge and to participate. I myself, I am in the green team and I saw that we are already laying behind. So the green team members, please certainly participate at the charity event. And tomorrow is a very important day for the Belgian delegation because they will try to defend their reputation of the after-conference dinner dancing and to equal the performance of the conference in 2001, also in Brussels. By the way, it's a marvelous opportunity for all participants at the gala dinner to do their bit regarding physical activity while attending the scientific meeting. And we will start this scientific meeting now with a welcome address. Our first speaker originates from a small country, but currently holds one of the highest positions in the European Union. It is with due pride that I announce Mr. Tonio Borg, European Commissioner for Health and Consumer Policy. And in the meantime, Mr. Commissioner, there is some light here, so you can come to this place. Thank you.
Ladies and gentlemen, welcome to sunny Brussels. I did manage to get some sun from Malta when I returned from my country, but it didn't last long, unfortunately. And as the moderator said, I happen to come from one of the smallest countries in Europe, indeed the smallest member state in the European Union, which is I always feel that small is beautiful. But I think the question today, as European Commissioner for Health, I used to have consumer policy, but that now is the responsibility of the Croatian Commissioner. The question we have asked to ourselves, is it shining in health matters in the European Union or not? And this is the subject which we have before us today. European health policy. Are we there yet? And before I reply to this apparently simple question, let me go a step backwards and ask, or better still, think of all the achievements of European health policy in the past 10, 15 years. We cannot see where we are going if we do not know where we come from. And I think in the past 10 to 15 years, we have launched a horizontal program on health. In fact, we are just about to get the third program adopted by the European Parliament and the Council. Of course, program, this is not a program of a conference, it's a program of funds, EU funds for health projects. Secondly, horizontally, we have managed to launch a health strategy and also a whole body of EU legislation developed on health. For instance, on tobacco products. Don't forget that we already have a directive on tobacco products, and what we are doing now, nearing, I hope, towards the end, is revising a tobacco products directive, which we already have. We have legislation on safety of organs, tissues, and cells. We have just now passed and approved the Cross-Border Health Threats Directive. Another piece of legislation relates to patients' rights to get treatment in other member states and be reimbursed for it by the home state. It has entered into force on the 25th of October, and I can assure you that I shall follow up this directive to see that all the member states, even those who are late, will transpose this directive in the shortest possible time. If not, of course, I am the guardian of the treaties and I have to apply the law. And we also have legislation on pharmaceuticals and clinical trials, which is also under revision. So the legislation within the context of the treaties is there. Don't forget that there is a very strong dimension of subsidiarity in health matters. We also have EU strategies and action. Strategies and action on a wide range of issues: HIV/AIDS, cancer, nutrition, alcohol-related harm, health inequalities. We are a European Union, but not a union enough on health matters. And this is evidenced by the inequalities in life expectancy and healthy life expectancy and in other statistics as well. And also have strategies. This week we shall announce certain results on antimicrobial resistance. We also have growing cooperation on e-health. This is the buzzword in modern times, particularly in times of crisis where we have to cut expenditure but retain the current standard of healthcare. Health technology assessment, patient safety, health workforce, and last but not least, cooperation on making health systems more efficient and sustainable. We also have mainstreaming of health concerns into a wide range of other policies and other community funds. I mention in particular the structural funds. We appeal to governments to use the structural funds not only for infrastructural projects like roads and bridges, but also for health objectives. And also the research program in particular, where practically 10% of the research program, which runs into billions, is dedicated to health. And also our policy, which is entitled Health on All Policies. So health is not only the responsibility or the exclusive competence of the Health Commissioner, but the health dimension should be introduced, as the treaty requires us, in all policies of the European Union. Our action, of course, does not end here, and I could continue with the list. But the question, which I have to reply to the best of my ability, is, but are we there yet? And the worst thing when one lists one's achievements is to become complacent and think that we are there yet. So my response is, well, we have certainly come a very long way. And I believe we are on the right track in bringing health to center stage at European level. So, without sounding evasive, I might say, in reply to this question, are we there yet? We are certainly in the process of getting there. And let me quote President Barroso's speech at the World Health Summit in Berlin only last month, when he said, "Health systems are the cornerstones of Europe's welfare. We must cherish their success, but also guarantee their future." So we already promote health as a value in itself. You know, the problem with putting forward health policies is sometimes that we justify them purely on economic reasons. That is to say that if less people smoke, then our economies will prosper because there will be less absenteeism and less disease. But let us not forget that the prime objective is treating health as a value in itself and keeping the human being, rather than our economies, at the center of our activity. But at the same time, while declaring that health is a value in itself, we recognize that health is a precondition for economic prosperity, but also social cohesion. And therefore it follows that spending on health is a growth-friendly expenditure. I spent 15 years as a cabinet minister in my own country. And most ministers in all member states look at health expenditure and health matters as if they were an albatross around our necks. By our, I mean by ministers' necks. Well, in actual fact, as we, I think, have sufficiently shown in our Investing in Health document, which we published with Commissioner Andor, it is also an opportunity. And therefore we believe that it is an opportunity for growth to invest in health as well. But we still have a long way to go. In particular, we still have to shift this widely held perception of health as a cost and further convince the doubters, the doubting Thomases, that health contributes to inclusive economic growth. This ambition underpins the Commission's policy, as I said, on investing in health. This is the title of our policy, which we launched some months ago, which recommends further engagement, first of all, to secure the sustainability of the health systems. Recently, we launched a panel of experts who can offer free, voluntary, non-binding advice to member states on the subject of sustainability. Promoting health also as a human capital and reducing the inequalities of health. And please allow me to take these three elements in turn and say something about them. First of all, sustainability of health systems. I am just stating the obvious. With the current demographic trends, where we have an aging population, the rising tide of chronic diseases, which is linked to the fact that people are living longer, so the chances of contracting a chronic disease or even dementia is much higher than before. And the increasing demand for healthcare, where everyone wants the best and preferably for free, these are pressures on the health systems, which mean that unless health systems are reformed, and I'm not referring only to those countries who are under some kind of program, but also to those countries who have a sound financial system, unless their health systems are reformed, those health systems are not sustainable. In fact, we already have 11 countries apart from the countries under programme, who receive country-specific recommendations on health, even though they have sound financial systems. And the financial crisis has, of course, loaded additional pressure on health systems and increased the magnitude of challenges which were already there before the crisis struck. And to successfully address these challenges, we need not one-off reforms, but structural reforms of our health systems, but we need smart reforms. We need reforms that respect our values, our principles, our traditions, which stimulate employment and boost economic growth. And our strategy for growth and employment includes a mechanism for economic policy coordination, the so-called European semester. And within the European semester, priorities for action at national and EU level for 2013 suggested reforms of health systems to pursue the twin aims of more efficient use of public resources and access to high-quality healthcare. And in this context of economic coordination, the Commission, as I said, recommended to 11 member states, large and small, you imagine who the small is, to improve the cost effectiveness of their health systems and to make healthcare less focused on hospitals. Of course, there is no one-size-fits-all solution, and the organization and the funding of healthcare systems remains a national responsibility. So I would like, by this comment, to allay fears that there could be that here is Brussels trying to steal something from the member states' competences. But the European Union can improve the context in which member states operate their health systems in practice and support them in their action. Let me give you just 3 examples. First of all, the directive on patients' rights in cross-border health care. So it's not just about going abroad and getting medical treatment and then being reimbursed by your home state, but it covers a wide range of patients' rights, including recognition of medical prescriptions from one country to the other. But for patients, this directive means empowerment, greater choice of healthcare, more information, wider recognition of prescriptions across borders. But this directive is also good news for Europe's health systems, improving cooperation between member states on compatible, I stress the word compatible, e-health applications and encouraging better use of health technology assessment. There is, in this union of ours, the tendency that everyone wants to introduce e-health in his own image and likeness, rather than trying to create a system which is interoperable with others. A second example, the cross-border health threats. So first we had the cross-border health care. This is the cross-border health threats decision, which just entered into force last week. This decision will help the EU and the member states to better protect citizens against possible pandemics, including a voluntary system of joint procurement of vaccines. Now, this decision will strengthen risk preparedness and response planning, and improve, as I said, through this joint procurement, access to vaccines, not only to ensure a sufficient supply in times of emergency, but to also to work against speculation in times of crisis. A third example. This is our European Innovation Partnership on Active and healthy aging, which brings together a wide range of stakeholders to develop innovative solutions to improve the lives of older people and improve health systems' performance. The partnership aims to increase the average number of years that citizens live in good health by 2 years by 2020. Should we have targets? I believe in targets. When you have a target, there is something to look for. Now, there was a controversial debate even within our services as to whether to have targets or not. But I believe in targets. So 3 spring to mind. We want to reduce the number of smokers by 2% in the next 5 years. That is 2.4 million smokers less in the European Union. Of course, this will be achieved not only by smokers quitting smoking, but by persuading young people not to smoke in the first place. Secondly, on cancer, we would like to reduce the incidence of cancer by 15% till the year 2020. And on life expectancy in good health, we would like to increase it by 2 years by 2020. So let us give ourselves a rule to measure our activities, our targets, our ambitions. If we succeed in being more ambitious in practice, that's even better. And the partnership on healthy aging and active aging is contributing to this conference and will highlight both the potential of healthy aging as well as the challenges it poses. Let me now turn to the second aspect of investing in health, promoting health as a human capital. Why? Because good health is not only good for individuals, it is also good for the economy and also for social cohesion. And we need, therefore, to continue exploring opportunities offered by patient empowerment and health literacy. We also need to step up work to promote health and prevent disease. You all know, statistically, governments in the member states dedicate only 3% of their health budget on average, so some have even less, to prevention. And this has to change. A long life in good health starts, however, at an early age, when many health behaviors are established. And the Commission is actively working to support the development of effective programs in areas including nutrition and physical activity, combating smoking, reducing the harmful use of alcohol, vaccination, cancer screening, and the management of diabetes and cardiovascular diseases. The third element of investing in health calls for reducing health inequalities. In September, the Commission published a report which showed that health inequalities between member states in terms of life expectancy and, in particular, infant mortality had significantly narrowed in recent years. This is good news, but much remains to be done, particularly in relation to inequalities in health between socio-economic groups. There can't be a system of health for the higher income groups and another for the lower income groups. So we must remain committed to fighting this issue. Successfully reducing inequalities in health will improve economic performance, reduce poverty, and contribute to social cohesion, but we do it because it is right. Ladies and gentlemen, let me conclude, I hope. This conference provides an excellent opportunity. An excellent opportunity not only to take stock of where we are in developing the EU health agenda, but also, I'm going to use a strong word, to galvanize commitment to invest in health, to support European health systems, and to achieve better health for all. with apologies to President Obama, together we can. And indeed, may I add, not only can, we must continue to work towards our shared goals of sustainable, patient-centered health systems with equal access to good health for all European citizens. So in answer to the question, are we there? My answer is, together we shall get there. Thank you very much.
Thank you. Thank you very much, Commissioner Borg, for your wise words. And now we will move on to our next speaker, who graduated from the University of Liège, where she studied law. Between 1981 and 2003, she practiced law at the Bar of Liège. However, we asked her for this welcome address because of her current job. Ladies and gentlemen, I proudly introduce Ms. Laurette Onkelings, Deputy Prime Minister and Minister of Social Affairs and Public Health of Belgium.
Thank you. Ladies and gentlemen, it's really an honor for me to open with you this 6th European Public Health Conference. As Commissioner Borg said, we are confronted in Europe with big challenge due to an aging population, the burden of chronic disease, and the burden of mental disorders, huge health inequalities, increasing patient expectations, rapid technology development, and growing cost of health care. At the same time, we have less resources due to the current economic condition. Health should therefore remain a core priority in the future, and investing in health and reducing health inequalities is important because it is one of the cornerstones of sustainable development. Health is a value in itself, and it's also a precondition for economic prosperity. The health of people influences economic outcomes in terms of productivity, labor supply, human capital, and public spending. In the future, we should also invest in the health of people, particularly through health promotion programs and ensuring universal health coverage as a way of reducing inequalities and tackling social exclusion. And I will speak about the situation here, in Belgium. Financial access to health care has indeed been a key issue of Belgian policy in recent years. Belgium is known for its excellent social protection and health system. Almost the whole population, more than 99%, is covered by a very broad benefits package. The reimbursement of health services is depending on the type of services provided, income and social status of the patients. For more vulnerable population groups, several measures were taken to ensure the access to high-quality care. Despite of these measures, there exist differences in health between socio-economic groups in Belgium. It has been shown that people in the weakest socio-economic groups do not live as long, do not enjoy what is perceived as good health for as many years, and spend more years of their lives suffering from what is perceived as poor health. In addition, rather than a pattern of ill health concentrated in the most fragile groups, while the rest of society enjoys relatively good health, the social gradient in health has been clearly demonstrated, where health outcomes improve as socio-economic status improves. These existing health inequalities have been stable over time. I'm very sensitive to this topic. Health inequalities are an injustice. It's a threat to those who are affected by it, but also to us all. No society can live in a sustainable peace without equality and solidarity and without justice. Therefore, we have integrated 4 important public health topics in the long-term vision of the Sustainable Development 2050, which was recently approved by my government, namely 1, improve healthy life expectancy and reduce the existing health inequalities with 50% in 2050. 2, access to high-quality health care for all, including vulnerable groups. 3, reduce the morbidity and mortality of chronic disease, including mental health. And finally, 4, tackle the negative environmental effects on health. My administration also participates in the joint action on health inequalities in order to increase capacity building in the field of health inequalities, health impact assessment with an equity focus, and health in all policies. In the frame of this joint action, Belgium has organized a policy dialogue in 2 parts. In the last month of June, I presented the results of this policy dialogue to the fellow health ministers in Belgium in order to get their commitment to start with an interdepartmental and cross-governmental working group concerning health inequalities. This working group has recently started working. This group should develop a national action program with the end of the next year. In order to reduce the existing health inequality in Belgium with 50% in 2050, it's really crucial to have a common strategy shared by all actors involved in this struggle. It's important to achieve mainstreaming health and health equity in all policies. Therefore, the program is crucial, and it was also to be an answer to the health policy of the WHO European Region Health 2020. In addition, I have also recently established a specific task force in order to make healthcare more accessible to migrant population. Furthermore, we have in Belgium already different national plans to give an answer to these big health challenges. I will not present an exhaustive list of every plan that Belgium has done and still does in the field of health. I will just give 2 examples, namely the plan of chronic disease and the HIV plan. The plan concerning chronic disease is a further development of the Council conclusion on chronic disease, which were prepared under the Belgian presidency of the European Council. Next week, we will organize a big national conference on chronic disease. This conference is one of the steps to the further implementation of coordinated and integrated provision of health services on the basis of WHO's vision of health to 2020 and the conclusions of the reflection process of the Commission and of the reflection process of the Senior Working Party. The coordination and integration of the provision of health services implies that people receive a continuum of health protection, health promotion, disease prevention, diagnosis, treatment, long-term care, rehabilitation and palliative care services by the different levels and sites of care within the health system and according to their needs. The services considered span of the full spectrum of care with settings cutting across this continuum at the varied levels and sites for the provisions of service. It's an instrument to remove gaps in care or poor coordination of provision of services towards a more people-centered health system so that improvements in health level and equity may be fully realized. Recently, I have also launched the HIV plan. So today, in Belgium, every person living with HIV can have multidisciplinary health care in a specialized center free of charge. Everyone in Belgium can have free anonymous testing, and everyone can have a free post-exposure treatment. We have a network of reference laboratories to monitor the epidemic, and we have given support to numerous associations and programs to work with high exposure groups. Progression of HIV has stabilized, but there are still 3 new contaminations every day. That is far too much, and that is why I propose to all my fellow health ministers to work out a national HIV plan. It was essential for me that people living with HIV are themselves involved in elaborating this plan, and that other sectors were also involved, like social integration, education, youth, and justice. It's a truly transversal and ambitious plan to give a better response to HIV in the 5 next years. We have focused on 2 high-risk groups, namely men having sexual intercourse with men on the one hand, and the migrant population on the other hand, and at the same time we have to fight the inequalities they suffer. Policy making and decision processes should be evidence-based and supported by adequate health information system. Therefore, there is a need to more multidisciplinary research in the public health field. The existing evidence should be translated in easy, understandable policy briefs in order to convince other sectors of the importance to invest in public health. And finally, it's important to measure and monitor the effectiveness of these investments in order to make the health system more sustainable. In Belgium, a cross-governmental task force has developed and put in place a procedure in place to assess the performance of the Belgian health system. Based on the results of the performance reports, the existing health policies will be fine-tuned in order to make the system more efficient and sustainable. We must work together across sectors at local, national, international level, and with the international organizations to rise to these big health challenges. Health promotion and disease prevention are key factors for long-term sustainability of health system, as well as increasing the years of healthy life. But don't forget the objective of equity in the development of health promotion and disease prevention programs to close the gap in health inequalities. I'm glad to see that this public health conference pays attention to topics related to this challenge, and I wish you all a very successful conference, and I hope that the conclusions will help us to make further progress in the field of public health.
Thank you very much, Ms. Onkelings, for your inspiring speech. Ladies and gentlemen, the European Public Health Association, better known as EUFA, is co-organizer of the European Public Health Conference this year for the 6th time already. And since 2010, our next speaker has been president of EUFA. No doubt that a lot of you will know him. Professor Walter Ricciardi, please, you have the floor.
Madam Minister of Health, Commissioner Board, dear colleagues and friends, when we started a couple of years ago the preparation of this conference and we decided to ask the question, health in Europe, are we there yet? We couldn't hope for a better start because essentially what the Minister and the Commissioner said, we want to look at the past, what we have achieved in the past 20 years, maybe learn from our mistakes, but also look at the many achievements that we have done, but also to look and to build together the future. EUFA in the past 20 years has grown from a relatively small to a big organization with 69 members coming from 40 countries, representing more than 15,000 researchers, practitioners, public health practitioners, educators and policymakers. And if we ask the question concerning the 4 pillars upon which we base our activity, we have different answers. If we ask the question about research, being Europe a natural laboratory for learning about health policy and health systems, we can proudly say that in Europe we produce one of the best public health research in the world. Of course, not only published on our European Journal of Public Health, but in the most important journal in the world. So essentially, we have contributed a lot to the increase and the production of knowledge for Europe, but also for the world. When it comes to public health practice, yeah, we can say partially yes, because during the past 2 decades, most European countries have made impressive progress in population health. And we can be proudly saying that this was achieved at a very low price because the investment that we had in public health are incredibly low in comparison with the results that we have achieved. And the financial crisis, as we have been discussing yesterday, is cutting in some countries the budget, starting in some cases from public health, and we have to be advocating against it because this, as Commissioner Borg said, is an investment, is not a cost. When it comes to policies, maybe we can be not so happy. The progresses that we have achieved have been uneven, and the health divide across the European region is unacceptably large. And maybe that we have to be to learn to be more active in advocacy for these people that cannot have a voice, in particularly when these people are hit by incredible vested and powerful interest in time of crisis. When it comes to education, I think we can be partially happy, but certainly together with our partner organization, we have to educate better our researchers, our practitioners, our educators, and our policymakers, not only to lead in the field of public health, but also to help other organizations and other individuals to be empowered to lead, because that's what we need. So, as said by the Commissioner Borg, we want to ask this question to us, but not only to make a theoretical response, to a theoretical answer, to start, as the Commissioner Borg, to galvanize our audience in order to stop crying, stop complaining about the crisis, and start in acting on that. We are very grateful that you came so numerous to Brussels from many countries, not only in Europe, and we are very grateful to our partner organization. I have to thank them all, and in particular I want to thank our full partners, the Belgian Association of Public Health and EuroHealthNet, We are also very grateful, of course, to the European Commission, both to DG Sanco and to the Executive Agency for Consumers and Health. To WHO Europe, the collaboration is marvelous. To the European Public Health Alliance, the Open Society Foundation, the European Observatory on Health Systems and Policy, and the European Health Management Association. I really wish you all the best for the next 20 years, hoping that we can, as said by the Minister of Health and by the Commissioner, work together for the best health of our citizens and for defend the people that do not have a voice in difficult times. Thank you very much and enjoy the conference.
Thank you, Walter. The next speaker is the president of ASFER, the Association of Schools of Public Health in the European region, together with UFA, co-organizer of the 6th European Public Health Conference. Professor Helmut Brandt, please.
Thank you very much. Dear Minister, dear Commissioner, friends and colleagues, welcome to Europe's capital of policy making and of public health policy making. This is my first speech now as past president of ASFER, the Associations of Schools of Public Health in the European region, as we just handed over the presidency to Vesna Bjegovic, sitting in the first row. She will guide ASFER the next 2 years. And we just celebrated that we have now over 100 members, over 100 schools of public health are now members of ASFER. And the Commissioner said he suggested to look back 10 to 15 years so that we can learn from the past. Just add another 5 years to this, then you are up to 20 years. And exactly 20 years ago, in the Treaty of Maastricht, the health mandate was created. So we have a young history of this. And on the other hand, we all know this history. So we can analyze it. And when you do this, the question in the end will be, is the glass half full or half empty? And you can debate about this. And we did this, and you can read about this in the European Journal of Public Health and other journals now, how this debate is going on. And it's good that we struggle about this. And the question is, when we now say the glass is half full, because we see the progress. Okay, there are some hiccups, but in general, it's nice. It's going well. But at ASFER, we are worried. Can we keep this process? Can we keep the status quo for public health in Europe? When you look at the consequences of the economic crisis to health, when you see the activities of certain lobbyists on health, can we keep up with this? Can we keep that this glass is being filled up further? And the big question is, what can we do? And not only we as organizations, but what can you do as individuals? Not only as public health activists or professionals. When we meet next year in Glasgow, we will have a new European Parliament. We will have a new Commission, because there have been European elections. And one of those things that you could do to make Europe a better place in public health for the next years too is to have your civil rights and vote. Go to the European elections. We expect a really small turnout at this election. It was below 50% the last time. It will be even less this time. Get in contact with those people who run for member of parliament. And when you are working in a school of public health, organize some seminars with your students discussing this. We have new rules how this parliament will be set up. It's getting more democratic. We have direct candidates and so on. And make health a topic. And if you do this, and you are multipliers, then suddenly people will say, hey, health as a European topic, so I have to have an opinion on this, I have to make statements on this. So my personal plea, and the one from ASFER to you is, go voting, organize this, help us to make a European issue out of this. We need a European movement about this, a social movement. And then we can reach that the glass can be filled up in the next years and will not going empty anymore. So I wish you a very good conference. On the one hand, the scientific level is high. We had very good abstract handed in. We already saw very good sessions. We will hear now a very good session, but enjoy it too, communicate, and think about it. Go voting. Bye.
Thank you, Helmut. I told you before, ladies and gentlemen, that this meeting will be one with a lot of variety and surprises. And already in this opening session, we will start with the first surprise. Although it is not explicitly and in detail in your program, it is on mine, and I can introduce to you a next speaker. He is a self-employed pipeline engineer, which of course you all had expected, I suppose. We asked him to add some couleur locale to this opening session, so he will talk about Belgium and Belgians and public health. Ladies and gentlemen, Philippe van den Abelen.
Good morning, everyone. Thank you, Professor Van Hol, for this kind introduction. I'm kind of having a sore throat today, so please bear with me. I may have caught a light sneeze, but then again, I'm reluctant to ask whether there's a doctor in the room, so please all remain seated. On my behalf as well, welcome to the 6th European Conference on Public Health, featuring the tagline, Public Health in Europe, are we there yet? Now, I am not a doctor. Well, strictly speaking, I am, but not in medicine, so I'm in no position to provide you with an answer to this question. Still, I'm glad to add that we do have the finest and brightest minds lined up over the next 3 days to address this question, to put it into perspective. So, public health, are we there yet? I don't know, but at least we're here. So, welcome to Belgium, the capital of Brussels. Oh, sorry, welcome to Brussels, the capital of Holland. The capital of Europe, well, it's a bit complicated, but still, here we are. We're organizing this conference in the shade of the atomium, which is our national statue. This is the body-centered cubic crystal structure of iron, I'll have you known, where the different spheres represent the 9 provinces of Belgium. Now, honestly speaking, since a couple of years, we do have 10 provinces, but that's a fairly complicated and long story, because it required our government to first vote a law in order to change the crystal structure of iron. Now, we recently added a tiny silver marble on top of this structure to represent the kind of particle that everyone assumes would exist, but almost no one could actually find. It's the Higgs boson, or the Anglaire-Brut boson, as we prefer to call it here in Belgium. So, you're looking here at the crystal structure of iron, but magnified, blown up in size 165 billion times. And that is why we chose this as our national statue, because it captures what we Belgians do best, exaggerating. And yeah, we Belgians tend to exaggerate, which kind of translates back in public health if you think about it. If you're a doctor in Belgium, you do have the opportunity to help or heal a patient every once in a while. But most of the time, you're merely a sounding board for people suffering from some kind of pleas disease. We Belgians tend to exaggerate. We have women with a broken nail rushing off to emergency services in pure panic, fearing that they might risk an amputation from the shoulder on. In Belgium, it has happened more than once that a doctor would give a person a flu shot and that he would return 1 week later perfectly healthy, yet complaining about phantom fever. I'm okay, doctor, but I can still feel the heat, that kind of complaint. So it's of little surprise that it was a Belgian pharmaceutical that invented a placebo for hypochondria. That's like a wake-up call for people suffering from insomnia, if you ask me. We have a Belgian patent on the placebo for hypochondria, although it didn't really work because the control group ended up less sick than they started. I'll let you dwell on that for a second here. Now, this is the crystal structure of iron, and we tend to exaggerate, so that's why we chose this as our national statue. Well, there's yet another reason. This is the structure of iron, and yet it was originally built using nothing but aluminium. Okay. Galvanized aluminium maybe, but still aluminium. That is because we Belgians are the founding fathers of the absurd. Okay. Even in the ancient books of the very first Roman emperors, our country was already penciled in as being Absurdistan. There you are. Which can be helpful for public health because it's one of the reasons why we Belgians don't have to worry about any causality between smoking and getting ill. But don't try this at home. This is René Magritte. This is not a pipe. It's a picture or a painting of a pipe. This is René Magritte. We have just across the room, just across the street of this venue, we have the René Magritte Museum. So if you have the opportunity to go and visit it, you'll get to know René Magritte, one of the famous surrealistic painters in Belgium. Used to live in Belgium. He's the one that told us an apple a day keeps the doctor away. There you are. And his paintings also provide us with an indication or an explanation as to why we Belgians are not susceptible to contagious diseases. So, welcome to Brussels, the capital of the country of the absurd. Now, indeed, if you were to read the local newspapers, and I have to excuse for our Vice Prime Minister there, if you were to read the local newspapers, we may not even be in Brussels here. We might have to organize a voting to decide whether we're part of the Flemish region or the Walloon region. I do understand that a fair share of you here today have traveled great lengths from distant places all over the world to end up here in Brussels. So allow me to briefly explain it, maybe in just 1 minute. In Belgium, a country the size of a pinpoint, we do have a federal government. We have a separate government for the Flemish region. We have another government for the Walloon region. We have yet another government for this Brussels area. And we do have some kind of government for people talking German, for whichever reason that might be. In fact, last year our government decided to create yet another government to govern the other governments. Now, Minister, with so many facets, our country just has to shine and glitter like the most beautiful diamond. Which is just a polite and diplomatic way of saying that our country is torn into so many pieces that we even had to stitch the bandage to prevent the patient from dying. So it's kind of a complicated country. Think of us as a tiny Switzerland, if you like, but then without the purple cows. But we do have the chocolates. We do have the chocolates. We have the waffles. We have the waffles from Brussels. Well, depends. We have waffles from Brussels or from Liège, depending to which government you're talking to. It's what we Belgians prefer to call the waffle are in politics. If the chocolates belong to Brussels, then the waffles are from Liège. Fair enough. We do have our famous national dish. We Belgians are so awfully proud of this one that it is known worldwide as being French fries. Still, while you're here in Brussels, do try them out with a big bowl of mussels. I can highly recommend it. And then last, but certainly not least, we have them Belgian beers, don't we? Oh, yes, we do. Now, I must admit, there's a fairly well-documented feedback loop between this generous offer and public health. Trust me, I've been there. I've done that. My humble piece of advice to you while you're here at this conference the next couple of days, don't try them all at once. Try them alphabetically. I recall when I wore a young man's clothes, I once had the audacity of trying them out in alphabetic order, only to discover somewhere the next morning that duvel starts with a D. So it will hit you fairly fast. Now, that's my 2 cents for this morning here. That being said, I'd like to return to this tagline, "Are we there yet? Are we there yet?" And I'd like to hand over the stage from the donkey back to the experts and Professor Van Hal, who will introduce the next keynote speakers. Thank you.